I'm a breast cancer surgeon at Marshall Clinic, and Mary and I have known each other a long time, and most recently came to her for shoulder physical therapy.
I'm Mary DeGran, part owner of Sport and Spine Clinic of Auburndale and Marshfield.
I was recommended to have an operation on my shoulder for a rotator cuff tear, and in considering that, because I couldn't even move the overhead lights in the operating room, I thought, wait a minute, I got to see Mary first. And at first we were in therapy like 2 to 3 times a week.
Yep, 2 times a week.
And I improved immensely, quickly, and I started thinking, because my shoulder was stuck and tender to examination in my axillary region, I remember saying to Mary, this is what my patients must feel. And so through the techniques of physical therapy, I started really thinking about how these methods could help my own patients. Historically, I never thought that my patients needed physical therapy, because I knew I didn't cut the muscle. I'm not cutting nerves. I'm operating on the skin and its contents. But my improvement, and from tenderness without an operation in my axilla to being able to easily move my shoulder without tenderness, we started to talk about how to get my patients in to see you. Something that I've also learned is that patients don't need to have complications from their operation to benefit from physical therapy. And there are a lot of patients who are having operations on their breasts, mastectomies, who have cancer, and who even are choosing to have that operation to reduce their risk of cancer.
A lot of times after somebody has their breast removed, or even say they had a lumpectomy, or even just poor posture, we start to get into ourselves, because obviously our posture and our breasts are really important for who we are. So we start to hug the lesion, or we hug what's been injured. So what we see is this is all tight, and then you have scar tissue, less range of motion, less blood flow to the area. So then when I ask somebody to lift up, they can't, because they haven't been able to extend through their trunk. So that'll affect their breathing, it can affect their heart, it can affect working out, being able to go for walks, pick up your kids, do anything up and over. And so you see a lot of people just being happy living underneath 90 degrees. But that's not really always living. And so we can give the opportunity to have decreased numbness and tingling, say down your arm, pain with coughing, even just, rolling in bed, fluffing the covers is a big thing that people have. Reaching out to the side to get, say, their water bottle, lifting that up, they might have problems with that. Reaching into a cupboard, being able to put clothes on the line, anything like that can be affected. And it's not just the breast, it's the shoulder, the tissue, the myofascial release that goes through the whole body in no rhyme or reason. It goes around the nerves, the muscles, the arteries, the veins. So it's really important that we get that all moving and basically increase blood flow so people can be active and enjoy life again.
And see,
because you may have saved them, but maybe not save them back to the life that they wanted.
And that's that aspect of breast cancer surgery, or breast surgery, that as a surgeon I've never regarded. Like, I've cut out your cancer. It's expected. But there's a big push in breast cancer care now, breast surgery care now, it's not enough to cure the disease. We want to improve their quality of life, get them back to their quality of life. And just my understanding of that role, I think, has really benefited my practice.
Mm-hmm.
And it's fun to think about, have that as an added aspect to surgical care. Is at the dinner table, how are things going? Making your bed. I couldn't make my bed with my shoulder. It hurt. And I never ask my patients how they're doing with their shoulder. It's like, okay, your mammogram's clear, or your exam is normal, and see you next year. So I think that focusing on quality of life concerns as a team has improved our relationship and our
Mhm.
patient care. So there are restrictions that we give to patients following mastectomy with reconstruction. And our plastic surgeons, they call it T-Rex arms, nothing above their shoulders. So they're staying like this. I've just sent my first patient to prehab physical therapy before the operation. I struggle with that degree of limitation. I was wondering if you could talk about what prehab might look like, and also your thoughts on what we can do during that restrictive postoperative period.
That's a great question, and there's a lot of things that you can do with that. So when we think about a shoulder surgery, or even people not being able to move just through here, what happens again is that we start to round. This becomes very, very tight. If we look at the muscles in the back, they become very lengthened, and so they become weak. So what'll happen is, if we can do something to promote chest expansion, we are strengthening the back muscles, which then inhibits that front tightness. So we're just starting to move the body in a different position. So we might be doing some of these. We might be doing up and over. We might just be bringing our body back like this, but it's a lot of education before the surgery. Like, what can you do? What can't you do? I think people get afraid and they plaster their arm next to their body, whether it's here or here. Getting out and walking, getting the blood flow moving, all helps you feel better. That blood flow is going to help you heal and have less restrictions with the bonds, with the tissues.
And that's all something you can do and still meet the restrictions of not moving your elbows above 90 degrees.
Correct. So there is a little different dynamic when we do put our arm above our head, but as long as we're keeping our trunk mobile, then we're doing well. We keep our trunk mobile, number one, because it has our heart, our lungs, our spleen, our liver, everything that's really important for us, right? So we somehow got these ribs. God gave us these ribs. I can say that. So we have these ribs, and they protect those organs. So it also gets more restrictive. So we see more people with neck and back issues because there's no ribs to help you. So then all of a sudden we're moving, and we can move so much, but it's not until we get our arm above us that the shoulder blades gets to glide upon our ribs. So it's really important that we start that before we even have issues, so that we know that we can move, because some people are so restricted just because of the atomic anatomy in that area.
So I never was a fan of this motion, and everybody's told that, okay, you can do shoulder rolls. Does that help? Is that something we should continue to tell patients immediately post-op they can start doing shoulder rolls?
Shoulder rolls are good. Inward, not so good, because we're always that way. Bringing them backwards, but it's not just the shoulders. It's actually the shoulder blade, the scapula, pulling that down and back. So you're opening up, which then takes our little pec minor muscle here and allows it to stretch.
Most surgeons don't want physical therapy to start until drains are out.
Mm-hmm.
Or can we do some of
Yes,
that?
you can do
while
that
drains
now.
are in.
Correct, because as you give that motion, it's also going to give some of that extra fluid away out.
Okay. I'm hopeful that prehab is going to catch on. I think, as I mentioned, we really are focusing on quality of life. Patients are focusing on quality of life. We can get a really good lobby as breast specialists and patient forum to then get insurance to cover prehab and to cover physical therapy in the postoperative period as long as it's needed.
Well, and we have to just think outside the box, because we are seeing now people prior to their knee and hip replacements coming in for therapy, coming in for 2 to 3 sessions just to learn what to do, get their questions answered. We have a little bit more time, that we have that availability to make a relationship with a patient.
So how would you answer this question? I get this question more and more often now. What things can I do to prepare for my operation? So bilateral mastectomy, let's say, for cancer or to reduce risk with reconstruction. I haven't been good at that answer, but I'm wondering if I should be telling them to continue to walk and move their chest wall.
Yes, walk, a lot of deep breathing, making sure that people are shallow breathers. They don't even know how to inflate all the way to the stomach. So you want to inflate that. Walking helps, it gets us our deep breath. A little bit more motion with the shoulder is all wonderful to do. If you're having a one-sided breast or one-sided shoulder, learn how to wipe your hinder with the other arm. That's really important, and you don't realize how important that is. Make little meals that you can do through here. Realize that you don't want to pick up a lot of things, but that you may want to stretch the arm out. Like dusting is always good. Anything that you're reaching across will give that.
All right. I think it's so important to educate patients, at least, about some of the expected complications and side effects of an operation and the role that physical therapy can play. And I remember specifically a patient who I saw after bilateral mastectomy at a 1-year follow-up, who, if she would do anything with her upper arms, her hands, knit as an example, she would swell. Her whole chest wall, extremities, everything would get swollen. And her non-surgeon physicians said, well, it's from your operation and don't do that. So at her 1-year visit with me, she wasn't doing anything. She wasn't moving her arms. She wasn't knitting, which she enjoyed. And I did know it was not specifically as a result of the mastectomy. And I sent her to Mary for continued evaluation and education, because we simply can't have our cancer patients, our patients who've had an operation, not do the things that they love. So, do you remember?
Right, I do remember her. She came from a fair distance, and we did a lot of education. I did myofascial release. We opened up those tissues. So myofascial release is, I just thought of something like a roadblock. Say that 41 has a crash, and you can't get through, right? So it just keeps backing up, and that would be like what the fluid does. So you have a roadblock, and all of a sudden she goes to do something, and it's not coming all the way up to get through her system. And so what'll happen is people are told, don't do it. Well, really?
But it's the myofascial system, it's not the lymphatic system.
Right, it's the myofascial system that is holding that. There's a roadblock somewhere in the system, and movement is just the way to get that back. Because if we don't move, it just keeps getting more congested and more congested. And then we put somebody in a compression sleeve. It may help for a while, but it doesn't change anything. So we have to change the perspective that life is worth living. And that's really where my passion is. I want people to return back to what they want to do. I don't want to say, well, just give that up. You know, my goal is to get you back to what you want to do and why life is there. So a lot of times we tell people don't do it. Well, you know, you think about it, you're knitting, again, your posture is coming forward. We might just need to prop that up. We might just need to give her little motions in between as she's doing that activity. But it's all the things, little things that you do throughout. It's not a half-hour exercise program. It can be a minute, 2 minutes here, stretching, movement in specific ways to help that patient. So that lady was very interesting. She came from about 2.5 hours away. So I had told her that, you know, the travel time was too much. So we did find a therapist in her area that would work with her, because she had seen therapy in the past, but sometimes you need a little different approach or a little thinking outside the box. And all therapists have a gift, and we all use it differently, and we all think of the body differently, but we're all different. So a different therapist may help you at different times.
Yeah.
So also, after seeing you for your shoulder, it's a big team, like, so if something else is bothering her, we want to promote that. So she was having issues with her left knee. And so fortunately, she was still able to walk 60 miles on that left knee. Can you tell me about that?
Yes, so I had an ACL repair, oh my gosh, 1983, so however many, 40 years ago. And for the last 3 years, it's been bothering me. And as I was in therapy for my shoulder, I asked Mary to look at my knee as well. With a walk coming up 60 miles for Susan G. Komen, I got an MRI, and it did show that I have torn medial and lateral menisci, and we were thinking I would need an operation, but continued with therapy for my knee. Was able to do the walk with very minimal discomfort, And it was really such a transformative experience. I cannot think of a better word. All of us being together. We had 32 members on our team. We were the largest fundraising team. It was transformative. I think it makes me a better physician. It certainly has made me a better colleague. We had a lot of physicians on our team as well. We've signed up to do it again next year. It's not going to be in Chicago again, so we're going to San Diego in November, and I want you to join us.
All right.
There's a lot of different ways that you can support and be a part of the team. But yes, I thought of you every step. My knee was good, and so my surgeon said, well, maybe we don't need to operate on you if you can walk 60 miles.
Right. So on our link that's following this, you will find another link that will go to help promote and help fundraise for the walk in November, next November.
Yeah, and more important than financial support is come be on our team. It's a great bunch of walkers.